Good afternoon, everyone. Thank you very much for attending this seminar. I'm very happy and honored to have this epoch-making event connecting Japan Endometriosis Society to World Endometriosis Society. I also very pleased to have two distinguished speakers from WES, President of WES, Professor Luk Rombauts, and former WES President, Professor Neil Johnson. Thank you very much, Luk and Neil, for joining us because you are very busy for your vacation season. And I also am grateful that Professor Taniguchi and Professor Koga will give lectures from Japan Endometriosis Society. So I welcome first speaker, Professor Luk Rombauts. His talks, endometriosis surgery for infertility is not as good as one would think. So please start your lecture.
Thank you very much, Tasuku. It's an absolute delight to be here with you today in, I guess, in virtual reality. And my greatest thanks to the organizing committee of the Japanese Endometriosis Society for the very kind invitation. So as you've said, I am going to be part in a debate with my good friend Neil, and I'm going to make the argument indeed that endometriosis surgery for infertility is not as good as one generally would think. Now, here are my disclosures. And so now that we are in 2023, I think we need to frame the question. I think the question of surgery or in vitro fertilization for patients with endometriosis-related infertility has become increasingly a complex one. And that is the needs of the patient, the skills of her specialist, and also the limitations of the local healthcare system are all making that decision-making more complex, and they dictate the solution. So we need to keep all of these factors in our minds. And when we look at studies, and there are quite a number of studies that can guide us, what we sometimes find is that, yep, there are some surgical teams out there that present really good results, leading to much improved fertility outcomes, but we need to be careful to make sure that those results would also translate to your center. Do you really have the surgical skills that that team in France or overseas has? So that's the question of external validity. There's, of course, also the cost of the treatment in different settings, different countries. We're quite blessed in Australia that IVF is very well reimbursed, but that may not be the same in other countries, and therefore surgery may be, for that reason, be the preferred option. And importantly, I think there are also some strong patient factors to consider. And in my practice, I'm both a laparoscopic surgeon, but also an IVF specialist. I feel that my patients often, if they come with infertility, their biggest goal is the quickest path, shortest time to their desired family size. We're not talking how can we get them to have one baby, how can we get them to have their full family size. And then there are other issues like etiology. If there is a concurrent male factor infertility, then obviously surgery for endometriosis isn't going to resolve everything. Do they need donor sperm? Perhaps there is the issue of maternal age. If she's already 42, 43, would you really consider surgery at such an age? So these are a number of things that we need to keep in mind. So why would one do surgery. Clearly, as medical students, we're all taught if you want a proper diagnosis for endometriosis, you need to do a laparoscopy to have that diagnosis. Although I think we're now moving away from that, and we're much more comfortable after ruling out deep endometriosis with ultrasound to start with empirical treatment without necessarily having a laparoscopic diagnosis. So I would not argue that that's a main reason. Certainly surgery for pain, unquestionably. If the woman is in debilitating pain, surgery can be one of those many options that can really result in good outcomes. So surely that is not the question either today. So I want to focus on the two remaining questions on this page. Surgery to improve natural fertility, is that required? And should we always do surgery, even if we want to consider IVF? Should surgery come before IVF to improve ART outcomes? And the way I want to do that is to address what I consider to be 5 fallacies. And they're listed here. The first one that I'll talk about is that surgery greatly improves fertility. Now, what do we know about surgery and endometriosis-related infertility? That yes, as you can see here from a large network meta-analysis that was published relatively recently, that if you do a surgical laparoscopy and you excise or ablate the lesions, that you do get a statistically significant benefit. You do actually get more women pregnant. And we know that this is based largely still on that landmark study from Marco in 1997, where he did indeed find that women with minimal and mild disease find almost a doubling of the number of pregnancies if they have their disease not just visually diagnosed, but also treated. But if you work out the numbers needed to treat, which you see in the red box at the bottom left, then you actually need to treat about 8 to 9 patients to have 1 extra pregnancy. And that's not the end of it. If you keep in mind that you need to actually do 3 times more laparoscopies, keep in mind not every woman with infertility will actually have endometriosis. So you need to do nearly 25 laparoscopies to have 1 extra pregnancy. And the question is that cost effective? Is that good value for money to do 25 laparoscopies to find 8 women with endo in which 1 will have an extra pregnancy? Now, another way to look at this is a diagram from the study of Marco. You can clearly see that after about 7 to 8 months, you can get a roughly doubling of the cumulative probability of a pregnancy. But if we look then also at what the actual expected pregnancy rate is in healthy fertile women, we see it's not a restoration of natural fertility. And certainly if we compare it with the predicted IVF success rates, and this is based on Australian data, then you could see that it lags behind the outcomes that you can achieve with IVF. Now, perhaps we need to look at more advanced endometriosis. So maybe the effects are quite small for minimal disease or mild disease, but what about more severe forms? So this is a study from Vercellini in 2006, where he looked at rectovaginal disease, and he looked at women that underwent radical excision, of course conservative, keeping the ovaries and uterus, but excising all the rectovaginal disease. And you can see that over 2 years, you can achieve roughly a 40, perhaps even 50% success rate if you have a really excellent surgical team. But Vercellini, interestingly, also looked at another group where there was conservative expectant management, so nothing was done. In actual fact, these women achieved the same pregnancy rates more quickly than those that underwent surgery. And another study from Vercellini, looking at the effect of repeat surgery, quite clearly shows that this is first-time surgery. And if you looked at repeat surgery, you can clearly see that it is very much the law of diminishing returns. The more times you operate, the less benefit that the woman will have in terms of cumulative pregnancy rate. So you need to make sure, if you are going to decide to do surgery, that the first one is the one that will count. There is also the endometriosis fertility index that was first published by Adamson and Pastor in 2010. It's the EFI index, and many of you will be familiar with it. And it was heralded by Carla Tomasetti as possibly the most important innovation in the past decade to optimize management of women with endometriosis-related infertility. And she considered it as the best and possibly only objective scoring system available. So what is the EFI? So it's effectively a way of trying to score what the impact might be of surgery. So we're looking here at a very distorted pelvis with really gross anatomical changes. And the idea would be that a very good endometriotic surgeon hopefully can restore the anatomy to a normal pelvis like you see in the left upper corner. And the degree to which he can achieve that goal is captured in the endometriosis fertility index. And so this is the scoring chart. So effectively assume that you have an excellent surgeon doing the procedure, and he might have turned that really awful looking pelvis into almost normal. You get almost high scores for most organs, maybe slight mild dysfunction for the left ovary and for the right fimbriae. And that leads to a least function score of 6. Then you need to also provide scores for historical factors, age, and other surgical factors. And in this case, we'll assume the patient's 37 years of age. She had 1 year of infertility, no history of prior pregnancy, so she scores only 1 for historical factors. And because she had quite severe endo, the AFS score and the least function score lead to a score of 2. And so she gets a total score of 5. So then you can tell the patient, all right, with an EFI score of 5, this is what you can expect over the next 3 years. But most women don't want to wait 3 years. They want to know how quickly they're going to be pregnant and have a baby in the next 6 to 12 months. And so if you look at 12 months, if you've done an excellent job turning that really very distorted pelvis into almost normal, if you have those surgical skills, you will achieve a roughly 25% pregnancy rate in that woman. Now, again, if you compare that with online calculators from the HFEA, so that's the British one and the American one's a SAT, and you assume that this woman could also have done 4 embryo transfers in 12 months, then you see you get a nearly 3 times higher success rate just with IVF alone. The second fallacy is that surgery can get rid of all the disease. And I think that is a fallacy because we do know that a lot of women with endometriosis will also have severe adenomyosis. Now, in Australia, we rarely operate on adenomyosis. I know in India and Japan, there are very skilled surgeons that can do it. And certainly if it's focal like this one, you might attempt excision. But we know that a lot of disease is relatively diffuse and surgery is probably not an option. And we know that women with adenomyosis, this is a systematic review again from Vercellini's group, that it is associated with a nearly 30% lower live birth rate, and there is also a pregnancy rate, and there is a nearly doubling of the miscarriage rate. And together that means that there is a double impact. The chance is lower to fall pregnant in the first place, and there is a doubling of the risk of losing that pregnancy. And this is a study, an older study from Ballestier's group, and it shows that women who have severe untreated rectovaginal endometriosis actually do reasonably well over 3 cycles of IVF, as long as they don't have adenomyosis. If they have adenomyosis, the outcomes are relatively poor. As you can see, it doesn't really change over the 3 cycles, and it remains low at 20% only. And this is reflected also in a systematic review that was done by Sunita Sharma. And what it shows here is that whenever you compare, for instance, a control group with women with endometriosis, or you compare women with endometriosis and adenomyosis against those with only adenomyosis, there is no difference. So whenever endometriosis is the comparator, it doesn't matter. It doesn't seem to make a difference in the live birth rate. But in all the other comparisons where adenomyosis was the distinguishing factor, then yes, you do find that there is a reduction in the live birth rate for those women with adenomyosis present. The third fallacy I believe we need to address is whether surgery actually improves IVF success rates. So that was that second question we talked about. Should you always do surgery before IVF to improve those success rates? Well, it's an interesting question. We know from this systematic review by Harb 10 years ago now, and these are all women that had endometriosis that was untreated. So the endometriosis was still present, because that's often a confusing factor in studies. These were untreated patients with endometriosis compared to controls. And if you look at the live birth rates, both for stage 1 and 2, compared to controls, or even stage 3 and 4, compared to controls, at the live birth rates were not statistically significantly different. So you wonder, why would you even consider surgery if it makes no difference compared to women without endometriosis? And it's also reflected in the SART registry, which is an enormous registry in America. And these would be women with endometriosis, a mix of women that didn't have surgery. Many of these women would probably have had their endometriosis excised. And you would believe that if excision made a difference, you would see that they would perform possibly better than women with other causes of infertility. And yet we don't see that. We see that women with endometriosis compared to all other diagnoses perform equally well across all age groups for both implantation rate and live birth rate. And this is another systematic review published by Barbosa in 2014, looking at nearly 130,000 women in 20 studies. And you can see that the live birth rate between controls and those with endometriosis was quite good, around 40%, 42%. And it made no difference whether they had mild or minimal disease or severe disease. But what I would like to point out is that those women who had endometriosis, presumably because of the impact of endometriomas or the surgery for endometriomas, that they had a lower number of oocytes collected, and that was statistically significant. And we'll come back to that point. Because, again, that is another idea that is out there, that if you have a woman who presents with infertility and she has an endometrioma, a chocolate cyst, that chocolate cyst will need to be excised. It will need to be removed before IVF treatment, or otherwise the success rates will be lower. And we do, again, have a systematic review that says that that is not necessarily correct. So there's two slides that I would like to show you. The first slide looks at the number of oocytes retrieved in those women who had their endometrioma surgically removed, compared to those women where the endometrioma was left behind. So we have really two women with, or two groups of women with endometriomas, but one surgically treated and the other not. And you can see that the number of oocytes retrieved remains the same. What was different is that the antral follicle count, as measured before the start of IVF treatment, was lower in those women where a surgical excision had taken place. So we know that endometriomas can lower the egg reserve, but certainly you're not making things any better by surgically removing it. It gets worse, and it should be no surprise that these women, as you can see in the third section, that these women required more FSH to get the same number of eggs ultimately. And the downside of having a lower egg reserve and requiring more FSH would be a fair trade-off if we did indeed achieve a higher live birth rate by excising the endometrioma. But that's the second slide here, and you can see that for all the outcome measures, in particular the live birth rate, which is obviously the most important one, that there were no significant differences between those women who had surgery and those who did not. Another argument that's often made in favor of excising endometriomas before surgery is that endometriomas can lead to abscesses when accidentally the operator sticks the needle in the chocolate cyst. And we do know that that is a relatively severe complication. It can be sometimes relatively difficult to manage and diagnose. But the question is that really something that's more prevalent? Is it a higher risk in those women with an endometrioma? And you can see when you compare those women with an endometriotic cyst versus the risk of abscess in the global population, so in women without an endometrioma, that the risk is not really significantly different. It is a relatively low risk. It's important to acknowledge that it exists, and you need to take the appropriate measures, such as intravenous antibiotics and oral antibiotics to follow, but it is not a higher risk compared to the global population. And then I come to my last fallacy. Often people say, well, it's keyhole surgery, in good hands, the risks of the surgery are quite negligible. And so there's only benefits in doing the surgery. But the risks are not that small. We've already touched upon the fact that the impact of surgery for endometriomas is quite significant. This is a systematic review which is a bit old now, more than 11 years ago, but that quite clearly established that there is a significant reduction of about 40% in the AMH levels after surgery for endometriomas. And that is often considered permanent. There can be some recovery, but most women will never recover their pre-surgery AMH levels. Secondly, whenever you do surgery, whenever you put instruments through the abdominal skin, the entry ports can cause accidental injury to vessels. More importantly, if you consider doing surgery for quite severe disease, for bowel nodules, rectovaginal nodules, we know that these women have significant risks of fistula, of pelvic abscesses, of requiring an ileostomy or colostomy. So these are not small impacts. These are quite significant, sometimes life-changing changes, such as neurogenic bladder dysfunction. So these women would clearly need to be consented and informed that this is something that might happen to them if they undergo severe surgery. So, of course, I've taken a quite strongly biased view, because that was what I was asked to do, is to advocate in favor of infertility treatment by IVF. And so I would like to conclude with the following slide. Is if the woman is not in excruciating, debilitating pain, and she wishes to have a family, then you should allow her to have her full family first with IVF. And quality of life, pain, can then come next, with surgery where needed, because there are also very good medical treatment options available. And I would like to finish very quickly with reminding you that this year we will be hopefully welcoming many of you in May in Edinburgh for our 15th World Congress of Endometriosis. Thank you very much.